Thank you very much. And I want to thank Jesse, Susan, Dr. Colley, and everyone for inviting me here and for putting together such a really interesting and comprehensive program of learning today. I've really enjoyed it, and I've learned a great deal. So I hope that goes for everybody else as well. Jesse had helped me by giving me a title, Is the Landscape Shifting? And I want to acknowledge that I believe it is. So I'm going to focus a little bit more on how, indeed, that's changing. I've had the good fortune of working on malaria for most of my professional career. Unlike Simon, I wasn't born with malaria, but I was born on Mosquito Lake in northern Ohio. A lot has been made of some of the historical background to malaria, and I'd like to start at the dawn of the 20th century. Just like the current turn of the 21st century, the turn of the 20th century was marked by really extravagant and phenomenal styles of facial hair. We've come full circle. We've mentioned Laveran and Ronald Ross. We haven't talked about Grassi yet, but Grassi is probably the forgotten of the trio, the one who did not win a Nobel Prize, but probably was the first to fully describe the life cycle, to demonstrate transmission from a mosquito to a person, again working with the bird malarias largely. We sometimes refer to the 20th century in geopolitical senses as the American century, and so I'd like to talk a little bit about two Americans, Walter Reed and William Gorgas, who took off from some of the work done by those other pioneers. Walter Reed confirmed mosquito transmission of malaria and yellow fever, notably by infecting himself with the latter. Gorgas took it a step further and took the principles of mosquito transmission and applied them to malaria and public health mechanisms by controlling mosquito populations during the construction of the Panama Canal. And there was a lot of attention focused on this, and that sort of became the idea that through effective vector control, we could achieve phenomenal improvements in the malaria situation, and some even eventually concluded that careful control could eventually lead to elimination. Two key tools developed shortly before and widely used during World War II were chloroquine and DDT. Paul Hermann Müller also won a Nobel Prize for discovering DDT. The Eighth World Health Assembly in 1955 called for a global campaign to eradicate malaria, based largely on the idea that we could deploy these tools, especially indoor spraying with DDT, and that there may be a limited window of time during which DDT would remain effective. Even in the 1950s, they were aware that widespread use of an insecticide could eventually lead to resistance. That, in fact, we now recognize as almost a biological inevitability. They were concerned that the opportunity for elimination or eradication of malaria would be limited by the useful lifespan of DDT. DDT became widely used for indoor residual spraying, applying it to the inside walls of houses. And the idea was that people stayed indoors at nighttime, and that the Anopheles mosquitoes that transmit malaria bite indoors and prefer to rest indoors. That's not always the case with some of the predominant malaria vectors. Many of them may choose to bite out of doors as well. It wasn't really until we had substantial developments in socioeconomic status and as Don Champagne mentioned at lunch, the electrification of rural areas where people would actually come into the households and spend their evenings indoors. So this strategy really became feasible only when there were advances in socioeconomic status and changes that brought people indoors of the evening. Other major activities were anti-malarial drug treatment, both for patients ill with malaria and occasionally as a mass treatment or as a chemoprevention tool, and some advances in surveillance to detect and eliminate any reservoirs or any remaining transmission focus, particularly in places where transmission was being reduced and elimination was being approached. We know we still have malaria today, so the obvious answer is the mid-century effort did not eradicate malaria globally, but it is important to note there were some successes. 37 countries eliminated malaria and were certified as malaria-free during that time period. But the story is much more one of stalemates and losses. In sub-Saharan Africa in particular, the global effort never really conceived that eradication would be feasible in sub-Saharan Africa. Based on the intensity of transmission, a highly effective, a highly efficient vector system, and poor health systems, the gains in the mid-century eradication effort were focused on the Americas, Southern Europe, to some extent South Asia, but never really was the focus extended to sub-Saharan Africa. In South and Southeast Asia, where there had been progress, we saw some reversals, in particular in Sri Lanka, where they'd nearly or virtually eliminated local transmission of malaria in the decades after we saw a resurgence. And in Southeast Asia in particular, some of the areas where malaria control was underway were interrupted by conflict in the middle part of the century. And there were, of course, the technical reversals, the advent and spread of DDT-resistant mosquitoes, as well as environmental concerns around DDT. In 1962, Rachel Carson published her book, Silent Spring. By 1972, DDT was eliminated for its use in agricultural or environmental applications. Now, many people don't realize that didn't necessarily affect malaria control right away. The amount of insecticide applied to the indoor walls for an indoor spraying program was very limited, and if it were carefully managed, the indoor application of DDT was very safe for humans and didn't pose a risk to the environment the way agricultural application did. The problem was that once you introduced DDT for household spraying, particularly in remote areas, it was very difficult to maintain control over it, and very quickly the pesticide would be diverted for use on agricultural fields. It also required careful protection measures for the sprayers and careful disposal patterns. So by 1969, the World Health Assembly suspended its eradication effort, never quite calling it off completely. And in the period between 1970 and 1990, malaria control largely disappeared as a global priority. In particular, vector control and IRS as a strategy fell out of favor, and there are some places in Southern Africa, South Africa, the Rhodesias, which are now Zimbabwe and Zambia, maintained aggressive indoor house spraying programs, as did India and other parts of the subcontinent. The global emphasis shifted from the focus primarily on vector control to one of diagnosing and treating malaria illness, when people became infected and when they became ill in particular. Again, the focus here, though, relied almost exclusively on chloroquine, which was still highly efficacious in the 1970s, but by relying on one class or one compound globally, this strategy was again vulnerable to the emergence of resistance, in this case, the parasites becoming resistant to chloroquine. There was also a paradigm that you needed to balance the gains achieved by natural immunity with effective treatment to reduce burden. And this was an approach particularly targeted at African populations who experienced multiple malaria infections throughout their life and developed partial immunity. Didn't mean they couldn't get infected with parasites, didn't mean they didn't get sick from malaria, but patients or individuals who survived intense malaria transmission and were lucky enough to live to be 2 or 5 years old seldom died from malaria in their rest of their childhood and their adulthood. And so there was concern that we didn't want to meddle too much with the natural immune process, even though it came at a heavy cost, 1 in 4 or 1 in 5 children dying before the age of 5. There was concern that if you did too much to affect that, you'd shift that burden of death to older age groups. A number of people have written about the Cold War metaphor, détente, as a metaphor for the state we were in malaria control. The decision to live together and to try to balance the natural immunity against efforts to reduce acute morbidity, severe disease, and mortality. There was also a trend at that time toward integrating. So malaria control, other vertical programs focused on a single disease or health problem, had sort of passed out of fashion. And the emphasis at that time was on providing basic health services across the board to develop horizontal programs focused on primary health care. And importantly, the science of malaria stagnated during that period, and the early promise of a vaccine, in particular one called SPF 66, which looked really like it was going to revolutionize our ability to control malaria, when it was tried outside of the Americas in trials in East, West Africa, and Southeast Asia, did not appear to provide any protection at all to natural infection. And so the donors sort of distanced themselves from further investments in malaria vaccine development. We're at a different stage right now, and in the 21st century, if we think about it now, we're at a step at the start of this century where we're starting to scale up some of the effective interventions that have been proven in the last 20 or 30 years. There was some progress occurring between the 70s and the 1990s. And at the same time, there were changes on the global policy scene. In 1998, the World Health Organization Director General created the Rollback Malaria Program at WHO, making it a cabinet program in her administration. In 2000, heads of state from 44 African countries met in Abuja and made a commitment to accelerate the deployment of proven malaria control interventions and to reduce malaria deaths in their country by 50% within 10 years. The Millennium Development Goals articulated at the start of the century specifically addressed malaria, HIV, and tuberculosis. And those three drugs were also, or those three diseases were also targeted by one of Kofi Annan's proposals that became the Global Fund to fight HIV, AIDS, TB, and malaria. This is a global procurement mechanism that allows countries to apply for grants that help them buy commodities for malaria, HIV, and TB control programs at dramatically reduced prices than they'd be able to do on their own, with huge subsidies from the donor community, and enables them to get commodities that are of globally recognized high quality. And for us at CDC, a key development was in 2005 when the President and then the Congress supported the creation of the US President's Malaria Initiative. On the science aspect, the real transformation occurred in November 2007 when it was Melinda, not Bill Gates, who publicly called on the scientific community to reconsider eradication as the ultimate goal for dealing with malaria. And her charge was primarily to the scientific community to identify the next generation of tools that would make that possible. And this is great talking in the biology building because nobody falls off their chair when I bring up the life cycle slide. But I wanted to go back to some of the biological basis of the tools we use for malaria control. Vector control tools are designed to kill mosquitoes or otherwise interfere with mosquito-human contact either before or after they've bitten an individual. And our other tool, diagnostics and drugs, act at different stages in the life cycle within the human. Most of them act here in the intraerythrocytic stages. We do have a few drugs that have activity at other life cycle stages. This is just a quick slide showing the focus of the President's Malaria Initiative, but PMI and malaria control in general now are based on 4 pillars of intervention. And it's interesting because well, at least the 3 most recent of these are important areas where the focus of partnership between CDC and UGA is really strong. And one of those is in case management, in developing and deploying new diagnostic tools and effective treatment. Another one is in deploying insecticide-treated nets to interrupt the human mosquito contact and to kill and reduce the number of mosquitoes. Still, indoor residual spraying has a value in certain areas. And then the third tool, intermittent treatment and prevention of malaria in pregnancy, which Julie Moore talked about earlier today. In the last decade, there's been a lot of progress made. These bars, I'm sorry it doesn't show very clearly here, but the lighter bars are data from different focus countries in Africa. The lighter bars are the earlier estimates, and the darker bars are estimates as of 2010 and 2011, and shows that the proportion of children using an ITN, a treated net, has increased in nearly all of these focus countries. In some countries making very dramatic increases, coming close to the target, the 2015 target of 85% coverage. Similarly, with preventive treatment of malaria in pregnant women, we've seen gains. They've been maybe a little slower, but in a few places approaching that 2015 target. This is a slide showing an area in northern Uganda where they applied indoor residual spraying. Each one of those gray bars is an IRS round, and this is the malaria positivity rate in children under 5. This is the malaria positivity rate in older children and adults, and you can see that with successive rounds of spraying, the proportion of people who are infected has dropped. Another important impact we've seen is that looking over time at the rate of all-cause mortality in children under 5 has declined in all of these focus countries over the time period when malaria control interventions were scaled up. Not all of this can be necessarily attributed to malaria, but there is good evidence that the malaria control intervention scale up in the last year has been associated with many of these reductions in child mortality. In its most recent World Malaria Report, WHO estimates that by delivering hundreds of millions of insecticide-treated nets, effective treatments, diagnostic test kits, that more than 3 million children's lives have been saved in Africa, and that's approaching the Millennium Development Goal of a near 50% reduction in all-cause child mortality in quite a few countries in Africa. But we also face some threats to malaria control right now. In the mid-20th century, the eradication project failed because of its over-reliance on a limited number of strategies, especially DDT, insecticide resistance, to some extent antimalarial drug resistance, although the real impact of that was felt a bit later. There was a lapse in global political will and a decline in funding. It's considered that as of 2012, the global investment in malaria reached its peak, and that it's been declining slowly since then. There has been considerable progress achieved, but we do see growing problems with insecticide resistance and antimalarial drug resistance once again. I'm a bit concerned that many people who advocate for us and have made the case to the President and the Congress that malaria is a good investment haven't prepared them for the natural fall off you'll have after achieving an initial large success. That rate of success will naturally even out over time. And then there are concerns that the global financial crisis will further constrain enthusiasm for investing in malaria. And then finally, I just wanted to talk about some future interventions, or at least note that to achieve malaria elimination, we're definitely certain that our current set of interventions can go further than they have, but aren't going to do the trick. And that new tools, where did I go with that? Here we go. New tools for vector control, such as rotating insecticides to decrease the probability of resistance, innovative vector control technologies, genetically modified mosquitoes, new ways of using diagnostic tests and treatment drugs, ideas we've talked about here today, like mass drug administration, or having a tool that could identify asymptomatic people and using mass screen and treat. Vastly improving the diagnostic tools so that we can detect those asymptomatic cases, and optimizing the introduction or mix of interventions. There may be tools we can do to change the behavior of that two-legged vector as well, helping people to complete a recommended course of antimalarial treatment, incentivizing health workers to use and prescribe based on diagnostic tests, and improving use of mosquito nets, improving our information system, and last but not least, the potential incorporation of a new generation, next generation of malaria vaccines that even if they're not perfectly efficacious, may contribute in the context of some of the other interventions. So thank you very much.
Thank you.
All right.
Questions for Kachur?
So you mentioned the mass testing and treatment.
Mm-hmm.
Coming from the veterinary world, veterinary diagnostics, this is some of the things that we try to do.
Mm-hmm.
And I was wondering why nobody mentioned it. What are the barriers to do that? It's financial.
They are financial. I think one of the barriers that we face is that to control malaria transmission, we know that a fair amount of malaria transmission can occur in people who have such low levels of infection that our current generation of test doesn't show them. And so I think the next generation diagnostic test will be important as a tool there. There had been concern that mass drug administration could lead to drug resistance. And so globally, it also kind of had the taint of the mid-century eradication era legacy attached to it. But in recent years, there have been some attempts to revitalize that idea, especially using some of the newer anti-malarial drug combinations. I think another element that would be important is a drug that would really address the gametocytes, the sexual life cycle stages that are responsible for infectiousness from human to mosquito. Right now we have primaquine, the only drug that's useful for that, and there are concerns about its safety if we used it in a widespread way. So better drugs, safer drugs that we could use to interrupt that stage, that link in the transmission cycle, I think would revolutionize our ability to use mass treatment or mass screen and treat as an effective tool.
Your slide on the Uganda and IRS spraying
Uh-huh.
showing the drops, then there was a comeback. What's happening there?
That is an area. Oops, how'd I do that? That is an area where there's definitely more to that story than I was able to explain when the slide was up, but. The first round of insecticide spraying, you'll notice, doesn't seem to do much. And that was with DDT. There was already a high level of resistance in the mosquito population. They switched to a pyrethroid insecticide, didn't do much. When they switched to a carbamate insecticide, that seemed to have an impact. And in subsequent years, they've been looking carefully at whether or not they've induced resistance to the carbamate class of insecticides in that area. So you're right, there is a more complicated story than I was able to tell quickly, but it does look like we're chasing resistance in this illustration here.